Yeah.
All right.
Fun shit. Yeah, it's really cool.
It is
Done it
2:00.
twice and both times.
We're gonna start our meeting. Welcome, everybody. Start with me reading the intro script. This meeting is being held virtually and in person and is hosted by the Utah Department of Health and Human Services in Salt Lake City. Public notice of this meeting was provided on the Utah Public Notice website. This meeting is being recorded. A recording of this meeting will be posted to the Utah Public Notice website no later than 3 business days following the date of this meeting. Every proposed agenda item must have a summary of the topic submitted no later than 7 days prior to the board meeting. Board members will present and discuss the summary. If no written summary is provided to board staff, the relevant agenda item will be removed from the agenda. Only items that have been submitted in writing in advance of board meetings will be allowed during discussion by the board chair. Public comment instructions. Public comments is limited to 2 minutes per person. If you want more time, you may request it from the chair. Please state your name and your affiliation. Only comments made on items listed on the agenda will be considered. How to make a comment over Zoom. When the chair opens public comment, use the raise hand icon on Zoom to indicate that you would like to make a comment. When you are called on, you will be taken off of mute. Take 2 minutes to make your comment. How to make a comment in person. Sign the public comment sign-in sheet with your name and indicate what agenda item you would want to make a comment on. The chair will indicate when it is time for public comment and invite you to the table. Take 2 minutes to make your comment. For additional information, to make a suggestion for agenda items or to contact board members or staff, send an email to dlbcboards@utah.gov. And with that, we will start the meeting. Did everybody get an opportunity to review the minutes from last month? Is there anything that you guys want to discuss or change? And
Move to approve the September 2025 minutes.
second it. All in favor, say aye.
Aye.
Okay, those are approved. Next, just for business, Chris is excused today. And we also we had an email come out late yesterday about our bylaws, if we want to kind of go over those right now. There was some Trevor went over them, updated things, kind of just streamlined them. If we want to go over those, some people responded, had some things that they wanted to mention, so if we want to go over that right now quickly. It's not going to come up on my thing, so I'm going to use my phone. But look at Misty had some, and I think Kent, you did too.
Yeah, I added some comments just directly into the document itself.
Let's see if I can't pull that up right here. Do you want to state them?
Yeah, I've got just 2 questions. First one, see if we can find. We've got it's under Article 4, officers. Section 1, it makes a statement that ensure that at least one individual is appointed by DHHS is appointed as the chair or vice chair. At the beginning in Article 2, Section 1, it says all members are appointed by DHHS.
The second thing is saying the chair has to be part of that representative group from DHHS.
As one of the appointees that come from DHHS.
Yes, you can't.
I was appointed by DHHS.
You can't have 2 from the industry.
Okay.
So you can't have 2 from UDAF.
Okay.
You can have 2 from DHHS, but you can't have 2 from UDAF.
And but he's saying that it says that everyone from the board is appointed by DHHS.
So if you go to Article 2. Or sorry, let's see. The new Article 2, which is members, 1A, be appointed by the executive director of DHHS. And so all members of the board are approved by DHHS.
Yeah, and the commissioner of the Utah Department of Agriculture and Food.
Yeah.
So there are several of you that are appointed by DHHS. Several of us, Matt, myself included, and some others, were appointed by UDAF. What they're saying is because they did not like that Matt and I served as chair and vice chair at the same time. There was a law change that required at least the vice chair or the chair each time that there's voting on those positions to be a person that was appointed by DHHS. So that's all that's saying is you just can't have two UDAF appointees in the chair and vice chair. And I think that does say that it'll be appointed by both.
So is it saying that all of our board members too will be appointed by DHHS and UDAF?
No, yeah, I mean, I guess it should say or, right?
Yeah, that's
Yeah.
probably. where I
DHHS
had it.
or UDAF.
That probably would.
Yeah.
Yeah,
I think we
okay,
put or in there.
yeah. I assumed that was what it was, but I just wasn't clear on it. So
Well,
thank you.
before we leave that,
Yeah.
one of my points is related to that as well. That was correct prior to my position becoming a CMCR appointed position.
Does that,
So
is
now
that
that-
appointed by the CMCR itself?
Yes, so now that has to be,
So then that has to be added as well.
yeah.
Yeah.
Cause I thought it was just a representative from the CMCR, but you're saying the CMCR chooses it, and as for you, they did.
Yeah,
Okay.
yeah, that was my understanding
That's
is
true.
moving forward, it'd be a CMCR.
Yeah, let's just, I mean, we can just check that in statute, Trevor, if that is true, we can change it.
That is correct, my understanding. is-
So then it would be DHHS, the Commissioner of the Utah Department of Agriculture and Food, or the University of Utah Center for Medical Cannabis.
Yeah.
Research, yep. So you gotta change that and to or, there you go.
Perfect.
What is what credentials do you need to be appointed from the CNCR? Is it anybody, or do you have to have like some? Do you have to have a degree?
Statute doesn't.
I don't think it's. I can tell you right now, it's not written up yet for the CMCR. We're working on that. But I didn't see anything in the statute.
Yeah.
Because I read it really closely as it came out, because I
Yeah,
remember originally I thought I was
moving out,
moving out, but.
because I would like to maintain like the PhD
Mhm.
criteria, not just an appointee, but somebody that we can turn to and say, what does
In-
the doctor say?
In
I mean, I think
most
CMCR
cases,
Set their own like informal policy, but
Yes.
and otherwise it'll have to be statutory, right? Cause for the rest of us though, Rich, remind me, for like Matt and myself, does it statutorily require that you have like a relationship, like you be employed by or have a relationship with a licensed business? In statute, it says that, right? So I think you'd probably wanna make that a statutory change,
Okay.
not just a policy change. Cause I imagine
Yeah.
the CMCR is not just gonna choose anyone off the street
I
to
don't
cool, come
think
represent
so.
us. But even if they have their own internal policies, you
Yeah.
probably want to spell it out in statute if you want that to be an
I think
actual.
that's
We
reasonable.
do, I don't know what you guys feel about it, but I feel like it's beneficial to just even,
I can't imagine it will be
With percep-
less than a PhD level.
Yeah.
Like, I would be hard pressed to think it would be.
Yeah, well, it could be clinical researcher is
Yeah,
the
yeah.
only, is the only differentiator. Yeah.
Yeah, I just think I'd find
Yeah.
it difficult to see them appointing
Yeah.
or recommending anyone that was not,
Correct.
you know, up to snuff, because that is representative of the center, so.
Yeah.
And then what was your other one? Was
Yeah,
on
very
quorum, right?
last page, I just want to make sure I'm reading this right. Section 4, regardless of the size of an established quorum, the board shall approve actions with a minimum of 5 votes. I'm assuming it's a minimum of 5 affirmative votes, or do we just need 5 people present voting with 3 being the
And
winner?
a simple majority.
Yeah,
I think that's
okay,
the way it is,
that's-
because otherwise we
Yeah,
couldn't ever do board business without 5 potential yes votes. And so
Correct.
if you did it this way, everything would have to be unanimous, and that can't be the way it is. It's a simple majority. So yes, 5 creates a quorum. And so then you'd need 3 out of the,
You need
three
a
out of
simple
the
majority
5
out
that
of
are
the-
present. Mhm.
okay, just
Yeah.
wanted to clarify that. Those were the
And I think
questions.
Matt was saying before, we've only had 1 meeting, or the lowest we've ever had in attendance was 6. And that was very early on when we kind of had that rash of people, you know, leave, those couple of people that left the board real quickly. So I think we've mostly been 7 or more every meeting, so. We should be okay.
I have one additional item, regarding section 3, item 6.
Article 3,
Yeah, which article?
In my notes, I said section 3, item 6. It's where it's in regards to consultations.
second is Article 3. Okay, yeah, Article 3, Section 3.
Old article.
New Article 3. Duties of the board.
Section,
Keep going.
you said section 3?
Article
said-
3, Section 3.
Or
There it is, number 6, right there, right? Is that it? that you
Yeah.
consult.
Yeah. Yeah, so,
UDAF or lawmakers, is that what you wanted to make it into?
yes, lawmakers or legislators, because I know I get reached out to by legislators for feedback on things,
Mm.
so. I don't know if that's just because of my involvement here or my research and expertise, but
So this is directly, it's basically repeating statute here.
okay,
So it's saying shall do this, not that you can't take additional actions.
okay,
But that these are baseline what the board shall do.
Okay.
Under statute.
right. Okay,
And then you guys probably, I hope you had a chance to read the email that I had. It was
Yeah.
interesting to find out that that had been a part of our bylaws since the beginning, but I think given that there's no direct statutory authority under the MCPAB statutes, we should remove the ability to have UDAF or DHHS be able to remove a board member without cause, just for the reasons that I stated. Not that I think that's going to happen or would happen. I just think that I know Brandon doesn't like me very much anymore. We've really been on the outs lately, and I know he's gotten to the commissioner over me. So,
Saying there's a.
We would
yeah. And I-
to protect that.
Well, I just-
Piss off you that.
To me, I think one of the best things about this board has always been the ability to have that public dialogue. Without fear of, something you say maybe getting you removed, without good reason. So yeah, I should have probably caught it when I was board chair. That's for sure. It's the first thing I thought when Trevor emailed back. I was like, man, I was new on the job, but it's probably not an excuse. So I think we remove it. And if there is other statutory authority, I think that's still statutory authority. I don't think we need to have it in our bylaws. And then for the mission and vision statements, I think it's okay that we remove the purpose for now because it is redundant. But I do think in the coming months, we should think of something along those lines. One, because I think it will help us to kind of all come together and decide what our mission and vision is. But also I think it's something we can then point to, for people outside the board, or if we're ever struggling with a decision, we can come back and say, hey, this is what our mission and vision is. Let's try to stick as closely to it. And I know, that other departments may be working on things like that for themselves. So I think it comes at a good time.
absolutely.
For sure. But otherwise, I thought Trevor did a good job revising. But yes, when I came across that this morning, when I got into my office to read it, I was like, I first thought to myself, I said, there is no way Trevor came up with that on his own. So wondering where it might have come from. He had said, actually, it's been in there the whole time. I said, oops, my fault. And so, yeah, I think unless anybody has any qualms, I think we just remove that section. And we can work on the mission and vision maybe in the coming months. We don't have to try to rush something together right now.
Like that. Do we have to vote on?
I think if we're gonna take action to amend our bylaws, I think we can say like basically consistent with the conversation that we've had on the record, we move to amend the bylaws. I think you can make a motion to that
I'll
effect.
second that.
Yeah. All right, I'll make the formal. motion. So-
Wait a
Yeah.
minute.
So I move that we amend the policy advisory board's bylaws in line with the discussion we've had today here on the record and in line with the comments that were made in the shared doc that everyone had a chance to see.
Second.
Imagine it's me unanimous, but
Do we need to do a roll call vote or can we just? vote?
You can just.
I can just,
vote. Do that.
yeah, all in favor of adopting that, say aye.
Aye.
Any opposed? Okay, that passes. Is there any other business you guys would like to discuss while we're in board business?
I'll bring it up. Do want to let you guys know that this will be my last meeting. I have tendered my resignation after today. And there's already been an email out to the cultivation facilities looking for a replacement. So hopefully by the next meeting, it sounds like that they're moving quick enough, they should be able to get one in place. So I appreciate the time and love serving on the board with all of you.
We've appreciated
Yeah,
you.
it's important.
You're gonna be missed.
Yeah.
Hopefully we find somebody equally as good.
and those application deadline October 31st, just in case anyone's listening and didn't see it.
Yeah.
Halloween.
Yeah, I don't know if Jimmy's on, but he also gave his
Resignation. Yeah.
resignation as well, so I've contacted a handful of law enforcement associations and agencies to try and give me some, that might take.
Yeah.
Tough to find those.
Didn't line up for you?
Yeah, they weren't beating your door down, Cuddy.
Yeah. That's Jimmy to play
Yeah,
a nominate. Yeah, you're right. Absolutely.
Yep.
But I think Jimmy is now the division director for driver's license. Right?
Okay, well, and wait, did you say if that was, if Jimmy's deadline for finding somebody was also gonna be October 31st?
I did put it the same time frame on the emails, what I already said is. Law enforcement, you probably have to like force them to do it. So,
Yeah.
I like it was first.
We're okay with that, we'll force them, no problem.
Good sport.
Okay, so, if we want to go to, agenda item number 3, the DHHS and UDAF update with Mr. Oborn and Dr. Forsyth.
Yeah, just wanna, it'd be good to start with something that we shared with the medical cannabis governance structure working group last week, which was some legislative proposals. And some of those are technical changes that I won't go into detail on just because they're technical. It's just correcting some things that we had in the statute. And Trevor is going to present a handout that we gave them. That is also, for those participating online, this is something that's been uploaded to the public notice website already, right, Trevor?
No.
No. Okay, and then after this meeting, Trevor can link it to the public notice website.
Sorry.
But yeah, so first, there's just 2 technical changes that are summarized there. I won't focus on those. But one of the ones that I think you'll be most interested in learning more about is the public education funding. So what this will do is clarify the statute to allow the DHHS Center for Medical Cannabis to fund public education campaigns. Not just focused on medical cannabis, but just cannabis in general. And we could do that from the Qualified Patient Enterprise Fund. And we just felt like the current statute wasn't as clear as it needed to be in order to give us confidence in doing that in compliance with the law. So, and the thought here is that we wouldn't be required to do the campaigns. This just gives us the flexibility to do them if we do feel we have adequate funding and an important message that we want to make sure gets shared with the public. In the past, our priorities have been patients and medical providers participating in the program and stakeholders. And so this just allows us to do this additional type of education. And so that's what that proposal is all about. And then a requirement that medical providers inform patients about potential effects. We know that the majority of medical providers already do this, but this would put it in the statute, so it would be statutorily required that they cover subjects specifically related to using medical cannabis frequently and effects that come with that, using it as a young adult, and also using high THC products. Those seem like very basic topics that should come up in conversations when a medical provider is meeting with patients. And so we just wanted to require those topics be covered in addition to subjects that are already mentioned in the statute. For example, a step that every medical provider is to take when they are recommending medical cannabis and visiting with the patient is they are to check the controlled substance database to learn more about other controlled substances that they're prescribed. And they're also required to screen that patient for substance use disorders and to consider the recommendation in light of any of those that they may have. Doesn't mean that if they have one that they can't receive a card, just requires that that be a factor that's considered and evaluated. So that's something else that we're recommending. And then also Not often, but on occasion, there are adults with disabilities that are interested in applying for cards, and their caregivers obviously are the ones helping them with that process. And they have a disability. Many of these individuals do not have their own driver's licenses or state ID cards. And so the purpose of this amendment would be to treat them like minors. And in the case of a minor, obviously, the minor does not have their own ID card or driver's license. We rely on the guardian or the parent to provide that. And so this would just treat them that same way when they provide verification of them actually being an adult with a disability. So
What would you count as proof of they are an adult with a disability?
that's something that we can evaluate internally, but we do have formal court documents. That's one way to do it. I
Yeah.
think that would be the best way to do it. And so there's ways for a caregiver, we can create in the software for them to upload a court document that would designate, hey, this person is age 40 or 30, but they have a caregiver that is the person that would go purchase product for them and would be able to possess that legally, although they're not a patient.
Right.
Right, so similar to how a minor is handled.
I think it might be worth clarifying an intellectual disability, just because there is such a wide scope of patients
Yes,
with disabilities.
Oh,
You want to be precise in the terminology.
right, and in the proposal, we've used the language of an adult with a disability who has a court appointed guardian. Right,
Okay.
because there's only, a select group that have a
Yes.
court appointed guardian. So that would be in the language and it's in the proposal. But good point, we would
Could-
want to make sure.
Could they do both? Because when they get a court appointed guardian, it's after the age of 18 and it's, sometimes just when the parents get around to it. Sometimes it takes a couple years, like if they're using the same doctors, it's not really high on the priority list. So could we run both? Like they could have an ID card or you could use the parents.
I mean, if they have. Technically, they don't.
We
Yeah, they
could,
don't need.
we'll take that into
Because they can still have
consideration,
their-
that's a factor,
Yeah.
it's possible that they
using
do
both.
have their own. Right, and,
Cause I think
Yeah.
if they have an ID, they wouldn't go this route, right?
right, they
They would
wouldn't
still go
but
through
we-
the.
Yeah, but I just
Yeah,
wanna make sure.
I
they
don't
can
think
still
that would
use
be a problem, they would just apply. And then the caregiver would also be able to apply and,
They say they're treated like a child, does that mean they have to go through the compassionate use
No.
board?
no,
No?
just in terms of like ID,
Got it.
that's what I.
No, I just wanted to clarify.
Clarify, right.
Just making sure.
Yeah, clarification.
Yeah.
Right, and we've had just very few cases of this, but we thought, okay, this does apply, and we've consulted with some people that work with adults, with court-appointed guardians and with disabilities in DHHS, and they've supported this, and so we've already shared these with lawmakers, and we wanted to make sure the board was aware of the proposal as well. So yeah, so those are 4 groups of legislative proposals that we have already shared with lawmakers, and if you have additional input, you're welcome to share that with our office and we can consider those. We don't have specific lawmakers who have already agreed to take whatever proposal we just shared once a week, so. Great. So yeah, that was first item, and then the CMC just posted new resources on its webpage. And these are intended for individuals who want to learn more about the medical cannabis program. For example, this one is a 1-pager that's being presented now. It's also, for those joining online, a handout on the public notice website, and it's already been uploaded to our website. But what this is something that might be helpful to someone who is a potential patient who knows nothing about the program. And it's a PDF, and so it may be a resource to stakeholders in the program, like a medical clinic, or a medical cannabis pharmacy or a patient advocate. As they share information, they're welcome to use this as something that comes from DHHS. That we've created that just provides the absolute high level basics. And then at the bottom, there's a QR code where people could learn more on a phone number and email address where they could learn more. So that's one new resource that we created. We'll be sharing these in different presentations, paper copy. But if any of you want to use this as a resource, it's uploaded to our website under the resources tab. You'll be able to download the PDF as well. Oh, also, we created a resource that is for medical providers who are new to the program or who are interested in the program. This resource is titled How to Become a Recommending Medical Provider. And as everybody knows, there's two avenues. One is to use the EBS, the other is to do it through a paper certification. So we've provided the high level summary of how a medical provider would navigate one of those paths if they choose to. And then a QR code where they can learn more on our website. So this could be a resource to patients as they meet with their regular primary care providers that may not participate in the program yet. Patient could share that to educate their medical provider. Also, medical cannabis pharmacies could use it and clinics could use it to share with patients who would share it with their providers. And patient advocacy groups may find it helpful as well. One thing that's unique about this is that it is something that the DHHS has created. And so oftentimes medical providers will receive things that maybe Utah Patients Coalition has created or a pharmacy is created, but a medical provider may consider something that comes from DHHS a little bit differently than they would from one of the other parties.
Yeah.
So that's what this is intended for. And we'll be sharing this in presentations that we're doing that I'll talk about a bit later, but it's just a hard copy that can be printed out for people that like having a hard copy for whatever reason, or something easy for a patient to physically bring with them to an appointment or something like that. Yeah. Great, so those are some new resources intended for individuals that don't have a clue about the program. And then a new resource that we created in addition to those is a PDF version of the patient product information for medical cannabis. So this is a version of the patient product information insert. It also exists on our website as just a web page, and that is what that QR code we discussed at previous meetings guides people to, is our web page. But some people would prefer to have a hard copy. So this is a shorter version of what's on our web page. It's shorter because you can't fit everything on our web page on 2 pages, front and back. So this is just a very basic, high level patient product information insert. So this has already been uploaded to our website under the resources tab, and medical cannabis pharmacies can use this to share with patients who prefer to have a hard copy. Also patients are welcome to, use this as another resource as they educate their friends and medical providers about the program. This is one resource that they can share with them and medical providers as well. So that's why we posted on the website, is it's not just a resource for pharmacies, but for everybody else in the program as well. And of course, we got input from this group as we created the content on the website. It's already there, and so this also reflects that input in the PDF version. So those are 3 new resources that we've created we know there's still people that love paper out there, so. And sometimes a visual representation is just something easier to use in a presentation setting. So we hope stakeholders find those resources as helpful as we find them when we do presentations. And if there's any questions about those, you're welcome to share those. And then we sent out last week a medical provider survey, the same survey we got your input on several months ago. This was sent to all licensed MDs, DOs, APRNs, PAs, and podiatrists. If they have a controlled substance license, we got the list from Doppel, all these licensees, there's over 19,000 of them. And so they all received this email. Now, doesn't mean they read it, but we know it got delivered to a lot of them, and because we've already received responses there's hundreds of them already responded, I think. So we're excited to see there's been already some response. Not only have we gotten responses to the survey, but I think about 50 have agreed to already do a qualitative interview with our office to talk about their thoughts about the program. And these are providers who have never joined the program. So we're not only doing the quantitative survey, but we're doing the qualitative one-on-one interviews with the medical providers. And it's all intended to help us better understand how we can improve the medical cannabis program from the perspective of people that haven't participated.
Right.
And getting their feedback is important. And it's a group we've never reached out to in this way. And the purpose is just gathering information. It's not to persuade providers to recommend medical cannabis. We're just wanting to learn more. So the Office of Health Equity is helping us with that, and DHHS, and they'll be the ones conducting the interviews. And they've done a lot of different interviews of this type with other groups, and they've done other quantitative and qualitative surveys. So, so there is a link to the survey that we sent in that email, obviously, and we're also reaching out to stakeholders such as Utah Medical Association, this group obviously, and also University of Utah, Compassionate Use Board, clinics, health facilities, to ask them to encourage their own medical providers to participate in the survey as well. So we've given them an example of text they could use in an email that they send to their medical providers. But it's always, of course, voluntary. If that facility chooses to take that step, it's up to them. So the deadline for medical providers to participate in that is November 21st. And that is a major project that we're in the midst of right now. And so you are also welcome in your own circles to share links to that survey if you know of medical providers that might be interested. And again, we only want those who have not participated in the program. This is not, hey, let's do a survey of medical providers that already recommend. That's not what we want. And then also UVU's in the midst of recruiting additional patients to participate in what's called the Sublime study. And Trevor's going to present what a flyer looks like that they have circulated. And we've sent this in our newsletter that we send out every quarter. So it went out last week. So this includes completion of confidential surveys 5 times during a 24-month period. And it's for the participants receive $40 to $50 each time they complete a survey. And it's an opportunity for those who have joined the program within the past 6 months to share information with us about their experience, or with the University of Utah about their experience in the program. Not just in the program, but also use of medical cannabis while they've been a card holder. And so those interested can email the University of Utah research team at sublime@utah.gov. The fancy acronym they have is, would you scroll up just a little bit, Trevor? Or scroll down, sorry. Is there, oh, okay, well, yeah, the email address is in other flyers. This is just one that was cut off a little bit. So the email address is, like I said, sublime@utah.gov, or the University of Utah research team can be contacted at 801-664-5771. Yeah, so that's an opportunity, again, only for patients that have joined this program in the last 6 months.
And that's for patients only, not caregivers.
Exactly,
Okay.
yep, just for patients, yep. And then medical cannabis market survey of patients. There's not a handout related to this one yet because the University of Utah team is updating the survey. It's being programmed in Qualtrics platform, and it's undergoing some final testing to ensure its functionality and its logic accuracy. But we plan to send that to all cardholders and individuals with expired cards. And the purpose of that is to learn more about some barriers that some of them may have experienced in participating in the program, or factors that led them to choose not to renew their card. So that'll be going to it should be between 1 and 200,000 individuals, because it includes people that have expired cards as well, not just those with current cards. So we'll send that out in the next few weeks. And there's just some final work that University of Utah is doing on that. And then also we're doing a health facility survey. And this was just approved by our agency institutional review board last week, but this is something that we'll be sending to health facilities in the state of Utah, the long-term healthcare facilities like assisted living centers and long-term healthcare, other types of long-term healthcare facilities, to learn more about the barriers that they are experiencing. And we all know that the federal law is a barrier, obviously, that many of them have in mind, that has caused them to maybe be reluctant to allow deliveries or whatever. So we just wanted to learn more, and we'll be sending that out likely next week. And I think, there's hundreds of these facilities throughout Utah, and we'll make sure we send it to all of them. And then we'll be reaching out with phone calls to follow up on that with them, to make sure they saw the email and answer any questions people have. And then we've got some upcoming presentations. One is on November 7th to the Southern Utah Family Medicine Conference, and Dr. McKiff is leading that. And this is sponsored by the Utah Association of Family Practitioners. And I'll be there with him to answer general questions, but medical providers who don't have a clue about the program, that's an ideal setting for them to learn about it. And then on November 13th, there's the Rural Health Association of Utah Conference that I will be presenting at. And that'll be some medical providers, but also health department representatives and public health professionals, people that work in rural health. Obviously, those are individuals that will be attending that, and I'll be using the handouts that I just shared with you at both of these events. So that's part of what prompted us to put some of those together. Also, as you all know, we send out newsletters every quarter, and our patient newsletter, last time we sent it out, it had a subscriber list of 1,200, and just wanted to share, we've increased that. The one we sent out last week had 1,600 subscribers. So we've been able to increase the participation in that list quite significantly, by about 400 in the last quarter. And then there's a medical provider survey that we send out, and that one we increased by even more. The former time we sent it out back in July, it was the 543, and now it's jumped last time we sent it out last week, we had 849. So,
What do you attribute that growth to?
one of the factors is we did update our website. And, I think that, we put the ability to subscribe to the newsletter in a more prominent place. And so we think that it was a factor.
Yeah.
We updated, we did that in July. And so just changing that, I think, what was likely the biggest factor. We've never had a jump like that.
Yeah.
I think that's why we just made it more prominent on our website and made it easy for people to see. Some general stats, we've got 104,402 active medical cannabis patient card holders as of the end of last month. 903 recommending medical providers who are, have accounts with the EVS by the end of September. And then we've got about 209 paper only, the limited medical provider group. And so that's a total of 1,200 medical providers who are participating in the program right now. And then we've got about 90 pharmacy medical providers by the end of last month participating in the program. So sorry, that was a lot, but hopefully you found some of that helpful. And
Rich, if I could make
Yeah.
a suggestion, in regards to the poll that you're sending out to facilities.
yeah,
Something you might want to consider also are hospice providers in the state. They're not necessarily locked into a facility, although they serve facilities,
yeah,
but they reach a lot of patients that are home hospice based
yes,
that otherwise aren't getting polled.
right, because they don't have a facility, but they're
Right.
home health.
Right. So I would, you might get a unique array of answers from those individuals.
Has a
Yeah.
higher turnover.
Yeah. So.
I hadn't thought of that, but that's a good, I know they have an association
Mhm.
that we've had communications with in the past, and it's a good idea to revisit that with them. Great, thanks. Okay, that's all. Yeah.
On the Sublime study. Misty asked, so it's caregivers cannot fill that out. Is there a way that we could make it so they could? Or is that?
There's reasons why the University of Utah restricted who could do it. It just impacts the quality of the data when it's someone that's not actually the patient that is taking the
Filling it out.
survey.
Gotcha.
That's what it relates to. And, keep in mind that they're also saying we only want patients within the past 6 months.
Yeah.
And with certain conditions. Because it just, it just impacts how they can sharpen the quality of the study. They can limit who they're targeting in it, right? But the market survey.
You can be a caregiver.
The way it's put together, I'll confirm, but I believe it does allow for someone to represent their caregiver.
Good.
Yeah. And it's a much bigger survey for any patient, former or current, who's participating in the program.
It will probably not be accessible then to hospice patients or Alzheimer's patients or other patients who can't access or complete the survey on their own.
That's true. We might, with that input though, I think there's ways to coordinate with the facilities,
Mhm.
like you were saying on that as well.
Yeah.
Yeah, it's a good suggestion there. Great,
You good?
thank you.
Hey, Dr. Forsythe, take it away.
Right. We just have a few items, so I see a project continue to move forward, things are on pretty good pace now. So planning on the February 2026 timeframe for launch. We're asking all of the licensees to help them going over their data to make sure that their data is system properly. So if any of them have not been contacted, I think we've had at least some contact with all of them. But if there's any out there that are not directly involved with that effort, they reach out to Anthony Garcia and make sure that they are involved so that they get their data reviewed appropriately and give them the system in a way that will be helpful to them. Additionally, we have the additional pharmacy license that is being awarded here shortly. The board has more or less finished reviewing all of the applicants, and they'll be meeting next month, November. We're supposed to be on the 13th, but that date might change to vote on the license to be awarded. We'll for an update on the date when that will take place, we need to check with the UDAP. So we have the presentation for the changes, suggestions. So we have some legislative proposals. Pages to 441A. That I can go over real quickly for you. Won't dive too deep into these. They're the same as what was discussed in the campus work group meeting of the legislature last week. And if you want, I'm happy to share the slides with the board if there's any interest there. Just very quickly, patients and producers were asking for the ability to put some terms on packaging associated with their products that would be helpful for patients to identify what the product was intended to be used for. Just simple descriptors that wouldn't necessarily constitute a medical thing. Something like sleep, focus, calm, relief, types of descriptors. So I'd like to see the statute amended so that producers could use those terms. Second, we're recommending that the legislature make changes to 441A-102, linking GMP compliance to potential reduction in testing requirements. This is something that producers have consistently asked for. There are rather stringent testing requirements for medical cannabis products, but we see that there is good reason to have those, especially given that producers aren't required to follow GMP practice. And those GMP requirements would basically increase the record keeping and the facility standards to a level where we would feel comfortable not necessarily trying the whole gamut of product testing for every single product, but rather do a reduced testing panel. But it would still involve some testing. We haven't fully worked out the details of that final product testing schedule, but it is something that we would be doing in rule if this was to get into statute. Licensing board is currently reviewing basically every little detail of the any change that happens on a license, renewing a license, any of those types of things. And a lot of it could be streamlined, reducing the board's need to vote on renewing a license if there haven't been any issues with that license and the past licensing term. So we're proposing that we get some changes just to reduce the number of things that they need to take any action on. They would still need to take action to issue a new license if there's any large ownership changes. If a pharmacy was asking to change locations, or if there was a significant or repeated violation for about licensing. This is another one that industry has been asking for, basically allowing the word hash to be used on products because it is a requirement that's within the industry. We'd still like to see it maintained as a ban on using it as a brand name or an logo, but allowing it to be used in limited cases, strength or a factual description of the manufacturing process. We're recommending some changes to the courier product handling. Currently, they're allowed 10 days to hold a product to try to deliver it to a patient, assuming that first delivery attempt doesn't work out. We're recommending some changes just to ensure that the cannabis product is kept in good condition while it's in their care. requiring temperature and safe storage, temperature management and safe storage. And then just some kind of quick fire ones. So we're proposing that a new fee be created on UDAP side, directing the transaction fee. It used to be $3, was reduced back to $1.50. We need that to go back up to the $3, but for that $1.50 to be directed to the UDAP's account to help pay for the ICS changes and for the general program on UDAP's side. And in 102, we're asking for the ability for them to either directly add more acceptable forms of ID or to give UDAP rulemaking authority to accept additional forms of ID. This isn't a problem for most patients, but there are a few limited cases where patients have had difficulty given our current selection of IDs that are accepted. We're asking the legislature to make a change to required for patient privacy training, transfer that over to Department of Health and Human Services. This is regarding basically the HIPAA training. UDAP doesn't really do HIPAA stuff. That's more on the HIPAA side, so it's more appropriate to be over there.
You've been an arm wrestle?
Unfortunately, we haven't had to. But the bridge is back, I can.
We're okay.
All right.
All right, in 603, we're asking the legislature to consider adding limitations on supplements, the addition of supplements to medical cannabis products. Whenever you add one drug to another drug, there's concerns with increased toxicity or potential drug-drug interactions. And we don't feel that UDAP is the appropriate organization to be making determinations on that. So we'd rather see that go to some other entity to make determinations or just not allow those additions to be made. Because it could get pretty complicated. Then in 201, we're asking the legislature to give the department 45 to 60 days to review ownership changes over 50% rather than just 30 days. This is just administrative on our side, just because of the way the board has been worked out. And then this is another one for Department of Finance, is just to remove the requirement for them to approve a payment provider, just to be that kind of point of the program. All right, and then we wanted to make some we want the legislature to make some clarifications in statute, basically explicitly allowing medical cannabis pharmacies to sell any cannabinoid product regardless of its final THC concentration. There was some discussion last time, there will be some additional discussion here about low THC products in pharmacies. We can talk about that one more. That's, although I don't think I can occupy 45 minutes with my statements there. So you might get that early. And then this one had already been in the works, but in 2005, give you that back authority to create the regions and limit the ability of pharmacies to move outside of their current region. And then just a minor clarification, replacing the term back panel in statute with cannabis back panel, which is commonly used by UDAP and the industry. And that's it.
Any comments about that, anybody? Okay, then we'll move on to agenda item number 4, medical cannabis education, continued with JD.
Yeah, so I presented on this last month with the memo, and we made a decision to kind of come back this month and provide some clarifying language or some potential amendments in statute to allow UDAF to provide education, because as you all remember, the statute does not, their statutes currently do not authorize them to provide education in the way that DHHS does. And so I looked to the 2 statutory sections that I thought would be most applicable 441A, excuse me, I said 41, should have said 41A, 104 and 441A 110. And 441A, I would propose that we just add some language in that allows UDAF to educate licensees, whether they be production licensees, pharmacy licensees, or couriers, since that is who they regulate, as well as the public regarding topics related to cannabis as determined by the department. The reason I did not say medical cannabis is for the same reasons that we discussed with Rich last week. And what I envision there, instead of kind of providing a laundry list, and I think we can talk about this, of what, UDAF could or couldn't do. I know Cody last time had said, hey, we may have an appetite for education, but it was something the department would want to kind of consider and not necessarily be, hemmed in by a list. I would envision that you all would be providing education on topics that you have expertise in, whether that be regulation, whether that be, quality control testing and those types of things, best practices, those types of things. I think it would differ, quite a bit from the education that DHHS would provide, or that the center would provide. So if we need to spell that out, I think we can, but I think part of it is just giving UDAF that authority, because we hear Brandon all the time, come to, different places and provide testimony about, the safety of Utah's medical cannabis products and the testing that it goes through. But you can tell people that in small settings, but right now you don't have the ability with your budget to provide that to the public. And again, it would be a may, it isn't a shall, right? So it's something if you felt, inclined to, but I do think sometimes, for those folks who are deciding to purchase in other markets, it might be at least useful to know, what you get when you purchase a Utah medical cannabis product, the testing that it's gone through and some of those things. I think it can help to explain a number of things about the products. But also I think, I've talked to the department, recently about, guidance for, for licensees, and, in the new role that I've been working in and dealing with different regulators, across the country and getting to know what they do, I see a lot of guidance being provided to licensees. Now, I'm not sure that's always clear guidance for those licensees, but there is guidance that isn't just, hey, this is the rule or this is the statutory section, and it's up to you to understand your interpretation, and we have our own. And the way you find that out is usually to get a letter of concern or something like that. So I think that could be a good place to be able to provide some of that as well. I think a great example is, if that, that limitation on strain names does go through, terpenes and flavors as well, being able to provide some guidance and some clarification on what is a recreational disposition. Another place had one of your inspectors actually come yesterday to our pharmacy, and they were expressing to us how certain licensees have, with the new rules, have been like, man, there's nothing in the rules anymore. There's nothing to follow. And I think, then again, I think there's some guidance there would be helpful to either direct people to say, hey, this section of the code of the rule was removed, but this is the section of code that could, that. And I think it would just give the, the department flexibility to do that. So that was more of what my thinking was there. And then of course, going down under 441A 110, I think in the spirit of kind of running everything by the policy advisory board, I think consulting with the policy advisory board over any public education. Because we have a member of the CMCR on our board, I think the CMCR would get to informally kind of review that education. But I don't, like, going back to what I was saying before, I don't really see the education that UDAF would provide being overlapping too much with what DHHS would do or the CMCR, because there is specific direction in statute as to what that education is that DHHS provides. And then you all consult with them, as, kind of as needed. And I think there's just an area where we're missing some of that education that I don't think DHHS, is an expert in anymore, since they don't regulate, some of the licensees, as well as the fact that they don't conduct the testing and some of that stuff, which has, been a calling card for our, for our program. Because really what you hope is that this education is going to help convince more Utahns to stay in Utah and purchase medical cannabis from a regulated source. But I also envision that some of the noise that we've been hearing, which we heard repeated again last week, there would actually be a way to disseminate some of that, that education, some of the things I think that you testified to last week, to be able to put that out there and help people to understand, those things. And I think that's a great place where there could be collaboration as well. So it's why I didn't get too specific with it. I think if lawmakers are inclined to do that, or if anyone around this table wants to make specific kind of guardrails or things that you can and can't educate on. I'm more interested in permissive as opposed to restrictive. So that's kind of the way I went with it. And so, yeah, I've got a motion prepared, but obviously all, ready to hear discussion as well, because I know there were some comments.
Anybody on the board?
I'll just add, I listened to the governance group last week and having the University of Utah present the importance of state education as it relates to illicit use in the state. I mean, there's a direct correlation there. So I think this continued push only continues to combat that effort. And so I think it's a.
Yeah, and that's exactly why I didn't put the medical cannabis part in there, right? Just cannabis in general, because I do think that's an important part, as well. And I don't know which agency is better to dispel some of the things that we heard. I thought there was a lot of good testimony, both from the agent, from UDAF as well as others, last week, to dispel some of the things that are being said. But I think that is a very important thing, because to me, prohibition has proven, I hope, to everyone that it's not the answer. While some may still think that is the answer, I don't believe that's the answer. And I also think that cat's out of the bag, like, pretty far by now. It's education and making sure if people do, need to, understand, potency. It's not around, prohibiting certain, form factors, or prohibiting, or requiring certain limitations. It's helping people to understand what it is they are getting and how to properly, dose that for themselves. And I think education is a far superior way to do that, as opposed to enacting limitations that are simply just going to force people to go find it from other sources. I think sometimes people think if we put a limitation on it, people just won't do it. I could probably think of 50 things sitting around this table where that just doesn't work. And so I think, just in the spirit of education, I think that's the direction we'd want to, hopefully move in. Sounds like DHHS is already going to propose some things in the legislature. So I think this is kind of in line, with that.
I guess we take a moment to do any public comment. I don't know that we need a ton. Do we have anybody that signed up to comment on this?
Rich, would you mind handing Des the sheet at the table? I'll comment sheet. I'm lost in my chords.
Chase, do you like to?
Yeah, I guess I'll just stand here. I just wanted to say that, when it comes to self-education, so we can
Yeah,
get your audio
yeah.
better.
Can you
Okay.
introduce yourself,
Yeah.
and if you're affiliated with anybody?
Hi, I'm Chase. I'm with myself. I just wanted to say that, yeah, state-sponsored education makes a huge difference, because right now, a lot of people are hearing of what they find out about, through people like me on Instagram. And I don't think that is where everything should come from, a lot of people put a lot of faith into the state saying something. So the more education we have, what the state is saying, hey, this is our program, and we're actually standing behind it. I feel like more people, will take that education and go, maybe there is a difference between this and what Phil on the street gets, But yeah, my main point is just education, especially where the state is saying, hey, we're talking about this, can make a huge difference for a lot of patients, even ones that are well versed.
Thank you.
At all levels too, not just with patients, but providers.
Bless you. Is there anybody online?
And
Sweet. Hey, back to the board for any further comments or motions to be made.
Do you want to make the motion?
I mean, I will, but I'm gonna just make sure no one has any other comment. All right, so I put this forward in the email. I'll try to make a succinct motion with it. If not, Trevor, what I put in the email to you is my motion. So I move that the board recommend the following statutory changes under Utah Code sections 441A 104, which is the Qualified Production Enterprise Fund creation, revenue neutrality, and 441A 110 department coordination with the advisory board. Under 441A 104, subsection 4 would be amended to be comprised of two additional subsections, A and B, which subsection B would be to educate medical cannabis production establishment licensees, medical cannabis pharmacy licensees, medical cannabis courier licensees, and the public regarding topics related to cannabis as determined by the department. And then under 441A 110, subsection 3 would be broken out into two additional subsections, A and B. And B would be that they would have to consult with the advisory board regarding the education described in section 441A 104.
Second that motion.
We wanna do a roll call vote?
Although. J.D. Lawrenson,
Yes.
Matthew Page,
Yes.
Ken Anderson,
Yes.
Lynette Beresney,
Yes.
Desiree Hennessy,
Yes.
Misty Smith,
Yes.
Kimmy Clark.
Yes.
That says 6 with 2,
Should be 7.
sorry, 7 with 1 being absent, 1
One
seat
being-
vacant.
Okay. Sweet. Okay. Thank you for that, JD. Moving along, to agenda item number 5, the medical cannabis THC potency. I'm just gonna kind of go off of the same memo I wrote last time and the couple times that we've talked about THC potency. I had one written, but I wanted to listen to how our meeting went last week, and then by the time we were done and we finished talking, it was late. So, but I think we're gonna be okay. The things that we did learn, again, from the meeting that we had last week with the working group, I think is that there's still no real reason that they want to restrict THC potency. I had kind of hoped that they were gonna come with some information that we would be able to then take and learn from and see if there was any reason to be doing this. The only things that they really cited was articles that they had read from like Washington Times, and none of that had anything to do with our state statistics. And so I did bring some of those just so everybody can understand. But so in Utah, we have a couple different things that I looked at. The teen usage, which is one thing that keeps getting cited. Since the medical cannabis program started, we are down in youth usage, 58% according to the youth risk behavior survey. That is done by DHHS, if I'm correct, right, Rich? And so, and then we also have the prevention needs assessment that is also shows kids, but it asks them, have they used within the last 30 days? That is down, about exactly the same amount. So we went from, with the teen usage, in the youth risk survey, behavior survey, teen usage was at 10% when we started the program. It is now down to 4%. In the prevention needs assessment, it was 8.2%. We're now down to 5.6%. There is.
And that's quite a bit.
That is-
below what the national average
That-
is too,
Yeah,
right?
we are still trending below the national average on both of those, which is also notable, right? But the fact that we have not gone up at all is excellent. We are not showing, I could not find any evidence of crime or diversion. You know, we did have Jimmy looking into that. He did not have any reportable cases. Our possession arrests in 2018 were 8,518. In 2023, they were down to 7,256. The arrest on sales. Now, again, these have nothing to do with medical cannabis products, but this is just, is the medical cannabis program making any of this trend upward? So sales arrest, black market product, not medical cannabis product. The arrests are down. In 2018, they were at 494. In 2023, they were down to 249. And so anyway, so looking at those, we are not having a public health issue with medical cannabis, but in talking to doctors, and I do wish Chris was here for this. But in, in talking to patients, in talking to providers, having the scope of being able to provide low THC product, being able to provide high THC product, and being able to have that regulated through the medical provider and with a medical cannabis pharmacist seems to not be causing any problems. And I can't, if we didn't state that there was a large amount of medical cannabis patients that use this for pain, they predominantly seem to need the higher THC products, and it just admitting that this is necessary, it would be a disservice to our program. So and the other point that I just can't stress enough when I look at THC potency is you can go to the health food store, you can get online, at, Intrepid, there's different CBD companies that you can get CBD from. That's available. We created medical cannabis pharmacies. When you go to a pharmacy, when I go to the store, I can buy Tylenol. When I go to the pharmacy, I can get Tylenol with codeine. When I go to the health food store, I can get CBD. When I go to a medical cannabis pharmacy, I want something that, I go through those hurdles because I want to be able to get something with higher THC potency. That's what the patients are using it for. I think that it's important to note that the two people in this room that would stand to potentially make more money if we lower THC percentage, because patients would have to purchase more. If they thought that would work, they would probably be behind it, but they know that this is going to force patients out of our market. It's still so easy to get other places out of state on the black market, and our prices are high enough that we don't need anything to incentivize patients to not use our tested pure medical market. And so this is, I simply, the more I look, the more I cannot see a reason why we would be asked to drop potency. But there is a bill file open, I hear, that has this in it. This is something that is going to be brought up this year. This is something that we are going to have
Who
to,
opened the bill file?
I wrote it down, but I don't want to say their name unless I'm absolutely positive. So I can maybe return and report next month with that name, but I don't want to say one that and be wrong. So if you guys want to know next month, I'll make sure to review that. So I don't know that it will get very far, but I know that it's going to be a conversation, and it's very important to me to be able to advocate for these patients that need the higher THC product. If they could use the lower THC product, we would not need a pharmacy, and we would not require a pharmacist. And so I feel confident that there's no problems in our program. I haven't been able to find any, and I would love to have a discussion on this if anybody wants to weigh in from the board, but at the end of this, I would like to have a motion, make a motion that we, as a board, if we can agree on it, that we send this message to lawmakers that we don't see any reason for potency to be dropped, and we'd like to maintain the current standards that we have now. So I'll open that up for discussion.
The only comment that I will share is that after hearing presentations at several meetings by various individuals, as I said at the governance meeting when I commented, it's important that any decision remain evidence-based.
Yeah.
And to date, I have not heard an evidence-based justification for limiting the way things are currently done. So until that happens, I think it would be premature and arbitrary to cap anything at this point. You don't see that with any other medication unless there's an evidence-based reason or incident to result in those types of restrictions.
Right.
And that, at least to my knowledge, does not exist. And should it become available, then we can open the discussion again, but to date, I see no justification.
Agreed. And you also mentioned something about like a toxicity, right? Like that's usually how these are justified, right? Like if there's
Right.
a toxic load or something, and we're not seeing those reasons. So I'm baffled. I don't understand why this is being attacked when it seems to be working and not causing any problem. But if the board doesn't have a lot of discussion, I mean, I feel like we've talked about this plenty. So, I do just want to point out that it's probably not because, people are unaware of this and they don't have anything to say, but we have pretty much beat a dead horse when we are talking about that. So with that, I will open it up to, public comment. If you want to speak to this, please come and state your name and who you're affiliated with.
And I'm Chase again, the big C. So something that I just wanted to mention on this is, as a patient, like many do with a high tolerance and that utilizes other cannabinoids, high THC products really fill a role for activating the CB1 receptor, where something like CBD may. So in my care, various cannabinoids come up for various purposes. And high THC products with my tolerance and with its specialty in activating the receptors turns up a bit. It's a very critical part of my care. So yeah, it would be disastrous, I'll put it that way, to try to, cope with something that's over THC percentage than products that work really well right now. Thanks.
Thank you so much. Is there anybody online?
This lake on other.
Blake, will you please state your name and who you're affiliated with?
Blake Smith, Zion Pharmaceuticals. Basically, I just wanted to echo what Misty said about evidence-based and being open to evidence. So I am doing multiple studies in multiple places across the United States, and we have some definitive data that now shows that cannabinoids or certain cannabinoids have increased liver enzyme activity in about 5% of the populace. So, and of that 5% of them have potentially dangerous activity within their liver where it can cause liver damage. And so, but the point is this, that's data that helps us inform what we should be talking about in terms of drug-drug interaction, all kinds of things that, like Brandon brought up, we need more data and more knowledge to do this. To just make an arbitrary decision to lower potency because 90% sounds high is uneducated, uninformed, and it actually doesn't do the program, patients, or any of the governing bodies any good. It doesn't make any sense from a science or a logical perspective. So thank you. That's all I have.
Thank you so much. Next up. Okay. What's her name? I can't read it. Okay, you are on. Will you state your name and your affiliation, please?
Aloha, my name is Kale. I am a pharmacist at Block Pharmacy. And I just wanted to put my input about the high THC stuff. As a pharmacist, I'm seeing patients on a day-to-day basis, and there are plenty of patients that need the high potency, but it does cause an issue for a lot of patients as well. One of my biggest concerns as a pharmacist is the studies that are starting to come out showing there's an increase in the psychosis due to the high THC. And there's always that risk versus benefit there when it comes to the THC potency. Another thing that I am seeing as a clinician here within the pharmacy is some of our top sellers are actually the lower potency THC with the higher cannabinoids showing they're having greater pain benefits from that. And most of the studies are showing a combination of them. So as a pharmacist, what I'm seeing here in Utah is a high amount of straight THC only or just high potency THC products and not as much of those ratio combination of them that is showing a lot more of the medical benefit for patients and showing way more efficacy in terms of the medicine.
Thank you, thank you. Okay, take it back to the board. Does anybody else have anything else to say? Oh, were you? Yeah. I'm here.
Sign sheet, you can't comment.
Really? Is that the rule?
It's your rule. You're in charge.
I don't make rules.
It's Matt's rule.
It's Matt's rule.
I'm not.
Okay, and Mindy Medea with PI Pharmacy and I'm a pharmacist. I just logistically, when we were talking about this, I have some thoughts. A lot of times higher potency products are important for patients who have issues like on autism spectrum disorder or children or palliative care who can only ingest a small amount, just do not swallow the orders. And then also there's certain patients that if you were to give them lower potency vape carts, they would be inhaling that vape all day. And there's a lot of safety concerns in my opinion. So if you have something high potency, then you just take one inhalation versus something lower potency and 20 inhalations. Then, so those are my thoughts that logistically with the products, I think certain issues are better off.
Thank you.
Thank you, Mindy, which actually brings to my mind what she says about autistic folks is that they have lower CB receptors. And so you actually have to take more in general to feel an equivalent to somebody who is not on the spectrum.
Yeah, to me, again, I think a lot of it goes back to education.
Yeah.
It goes back to dosing, right? I think there is a misconception about what THC potency really is. And I
Yes.
thought there was some good testimony last week, about how much you need to ingest with high THC potency versus low THC potency. But I think there are also some things to be said about, other cannabinoids and stuff as well. But everything I hear screams for education and helping consumers understand what they are getting and how to best consume that to treat their symptoms, as opposed to putting arbitrary caps in place that you go around the country and you look, it is just numbers that they've picked out of the air. Hey, 60% THC sounds like a safe number. All right, let's go with that. 20% flower sounds like a good number, right? They're always good round numbers. I've not seen anything that's like 23.6789, whatever, right? You just don't see those things. And again, I can understand where some of that is coming from, right? Because of course, we do not want high potency THC to end up in the hands of our youth, because we know the impact that can have on the developing brain. But again, I think it's been said again and again, if there is no actual public health crisis that is happening right now, that we would upend the medical cannabis program in such a way to only further challenge a program that already faces a number of challenges. It just doesn't make, it just doesn't make sense. And again, some of the folks that testified, no disrespect to any of them, but one of them admitted to lying to obtain his medical cannabis card and was actually asked several times on the record about that. Another person seems to not understand how cannabis is manufactured, and that was somewhat frightening, and she seems like she could maybe use some of that education. And then the other person, while he may be using, data and articles and different things he's found from different markets, he has yet to present one Utah-specific piece of data. And presumably, if this data is available in other states, that data could be found here. So I do agree with that gentleman in the sense that we should keep high potency cannabis out of the hands of our youth unless they have gone through and gotten a doctor's recommendation. That said, we disagree completely on where we go from there and how we get there. And I would like to see us, work on public education campaigns. And if we get to a place where, hey, despite everything we're doing, cannabis from the medical cannabis market is being diverted into the hands of the youth of Utah, we can always come back around to this. But to me, that seems like that might be something better addressed through parents and better addressed through law enforcement, as opposed to, arbitrarily limiting the amount of medicine that people can get. It seems like cannabis gets hit with all of these interesting limitations that other areas of medicine don't. And for some, in some ways, good reason, because there's not as much known about it. So we want to be conservative. But in other ways, a lot of this stuff is just recycled things that have been going on since, the 1930s. In some ways, to me, these arguments are no different than what Harry Anslinger used to say. They were just saying them in a different way and directing them at different people. So, I think, I also just want to thank some folks in this room. Missy, I thought you did an incredible job with your testimony last week. Nanette, and Des, and then Valerie, who I don't know if she's online or not, but I think it was good because while I thought, Scott Erickson as well as Justin, did a great job, and I know Blake always provides great testimony. Some of this I think has to come from people that don't make a living off of it. And it's nice to see that, we seem to all be in line here. But yes, Des, I would be interested to know, whether, publicly in this meeting or privately offline, who opened that bill file, just because I think there are conversations to be had with with that lawmaker or lawmakers, before we get to this, because something like this is just not it's gonna solve a problem that we don't have, and it's only gonna lead to greater attrition. We're over 75,000 or close to it that have left the program over time, somewhere in that neighborhood. And also, so I just think that this would just be another reason to say, hey, go find your cannabis from someone else.
Exactly, because if this really does go through into effect, it's going to raise prices for patients, and patients are going to divert from the program even further, and it will just leave us with an unfunctioning program. Yeah.
Yep.
Yeah, and I, again, like, if this was not a concern, I think, JD would be like, yeah, let's reduce potency,
Well, I'd
double the amount of income, but that's not what will happen.
Well, I imagine we would feel differently too if we had public health agencies or our regulators or RMPs, PMPs, all these different people coming to this board and or coming to lawmakers and saying, hey, we see this as a significant problem. I understand we heard a little bit of testimony about some concerns. I think a lot of that can be covered in education, but again, that's not my area of expertise. But I think it would be different. And I don't think that totally discounts where it's coming from. But again, I think these are people that either have no experience with the medical cannabis program, or I will just say it, a very interesting experience so far with the medical cannabis program. And unless and until they can, provide some actual data that is applicable to Utah, I think a lot of this is just noise. Hope I think he's still.
Yeah, we just welcomed him onto the board at this point. We had to.
Impromptu board member. He's replaced Matt.
Sorry, Matt.
I don't disagree with the overall tenet of it, but I do have to add that the psychotic feature is brought on by high dose THC used in a really chronic fashion, that it's very real. And I think the education to that, along with the adolescent use, is just really important. So I don't want that piece to be lost.
Right.
Because it is very real, and we are seeing it in mental health clinics across the
Can
state.
you show me where to find that data? Because I looked and I could not, I said the state shows no increase in mental health disorders. Valerie testified to that as well. She said it was like she's like, we're not seeing that. If there is that data, could we find it? And
You would have to talk to all these separate mental health clinics. I'm speaking just anecdotally based in my mental health clinics.
Right.
We are seeing that. And I know that's anecdotal and I can't say that crosses
but
the
so
entire
is
state.
cannabis.
I'm just saying it's a valid concern. I think the education is important.
Yeah.
So I don't want that to get lost in the mix.
Absolutely. And I think we can all agree on that. I looked for that data. Valerie came with data to say that it's not happening. So where is that going and how can we get it?
In my experience, it's really not. People come to your clinic, you diagnose them, you treat them, and you send them on their way. You know what I mean? It's not like you register that diagnosis somewhere or you report to the health department, oh my gosh, this guy smokes weed and he's super psychotic. That it really isn't a part of that process. So I don't really know where that would happen. So
Yeah,
I don't know.
maybe we think about that a little bit, because if that's happening, that would be something that would be something this board would want to know.
But I think there's also another thing, and I agree with what you're saying, but we're talking about non-medical cannabis.
Right.
we don't know what else is in the
There's
cannabis
mold, there's
products.
heavy metals, there's
we take
flame
it,
retardant.
we also don't know what underlying conditions are present in the patients that put them at a higher risk for these types of adverse events with the
Yeah.
use of cannabis. So again, it's
Correlation,
until there are
validation.
evidence-based studies performed, everything else is a case report or an anecdotal,
Yeah,
so we have to be very cautious before
yeah.
arbitrary decisions are made.
I totally agree.
But
I totally
absolutely,
agree.
yeah.
And in my experience, it's not all illicit use. Some of it is medical cannabis,
Yeah.
use,
Yeah,
like, but it totally anecdotal.
yeah.
I just don't want that little chunk of information to be lost because
Absolutely.
it's pertinent, and I think more research does need to be done, more information needs to be collected. But-
Great subject for an IRB.
That's what I
There
was
you
just
go.
thinking, like, awesome
Yep.
idea if we were able to have them send in.
Personally, I'd like to see an IRB of the higher doses in the geriatric population because that's also a concern of mine. People who are ambulatory but are using, there's already balance issues. I think that could be potentially be an IRB study, but I don't think any of these things are worthy of recommending potency caps.
Well, and in talking to Blake, and can hope maybe still hear us. I believe that we talked a couple years ago about specific terpenes that should be avoided if there was a mental health concern. And if that is out there, also, that would be such an amazing guiding light, like, we'll stay away from these specific terpenes and let's see if that's better. I mean, again, it comes down to education and understanding, and we're not quite there.
I'm just thinking from your lips to my grant reviewer's ears.
Yeah. Yeah. Okay. Anything else? Or shall I make a motion? Okay. I move that the board reaffirm that Utah's existing purchase limits of 113 grams of usable cannabis flower and 20 grams of THC in composite form per 30-day period remain unchanged and not be lowered unless credible science-based evidence shows a need to protect patient safety or public health, and that any concerns regarding dosage continue to be managed through these existing limits. Seconded.
Isn't it a
Wait,
28
wait.
period?
Just one caveat, to me, I don't think it's just purchase limits.
Yeah.
It's the potency caps as well. Those don't exist in the law, but I think that we need to make sure we're guarding both.
Right.
Yeah.
Well, and
throw form
that's how
factors in
we
too.
kind of chose to do it. I'm happy to change any of that language, but that's kind of how we chose to do it, is like, this is what you get per month. However, whatever form you decide to purchase it in, like if you want to grab some RSO or you want to get some 10 milligram gummies, this is your amount for the month. That's
Yeah,
20.
for sure. No, I don't disagree with that. I just think that they are aiming at more than just that.
Right.
And I think that recommendation just, while it reaffirms what's currently in the law, I think it falls short of saying that we recommend against any form of potency caps on THC or any other cannabinoid. As well as probably, the limitation, purchase limits, but as well as I think limiting, currently available form factors.
Okay. Well, then let's discuss what I can change there, because that
I
was,
think you just need to, I think everything is good. I would just say that where you talk about the purchase limits, that we reaffirm that. And that we oppose any legislative changes that would limit the amount of THC or another cannabinoid that can be present in a medical cannabis product. Or the form factors that a patient can purchase.
well, how about you write that right here so I can read it off?
You want
Because you speak faster.
Oh, like form factors that, yeah, I mean,
I don't limit it until, well,
I'll leave that to the scientist.
without an evidence-based review.
Yeah.
Yeah, I just want to make sure we're going broad enough, because I think what you have
Yeah.
is good. I just think that, as we know,
Okay.
that group is after pretty well everything.
Right, so you said, patient safety or public health, and then oppose finish that sentence so I can. write down and reread it.
Oppose any
Additional
additional,
potency limits.
Limitations.
yeah. on THC or any other cannabinoid.
We just put any cannabinoid,
Yeah, because THC smokes.
yeah, any cannabinoid.
Okay, I will take out THC.
Or other limitations on form factors that are not supported by evidence-based research.
Yep.
See, I did use that word. I said I wasn't going to.
I know.
Right, limitations on form factors without evidence-based.
Research, I guess.
Evidence-based justification.
Thank you.
Should pull that with the thesaurus.
Yeah. Okay, so I'm gonna read this again and then you guys tell me what you think.
Types the best.
Also, thank you so much for input. So it would be, I move that the board reaffirm that Utah's existing purchase limits, 130 grams usable cannabis flower and 28 grams of THC in composite form per 28 day period remain unchanged and not be lowered unless credible science-based evidence shows a need to protect patient safety or public health and oppose any additional limitations on cannabinoids or limits on form factors without evidence-based justification. And then I can add the last sentence where it says that any concerns regarding dosing continue to be managed through these existing limits, but I don't know that we need to.
Wouldn't it be additional limitations on cannabinoid potency?
Yeah.
That was left out.
Let's see.
Okay. Any changes or do you want me to make a motion and leave it there?
I think that sounds good enough.
Okay. Here we go again.
Oh.
I move that the board reaffirm that Utah's existing purchase limits of 113 grams of usable cannabis flower and 20 grams of THC in composite form per 28 day period remain unchanged and not be lowered unless credible science-based evidence shows a need to protect patient safety or public health and oppose any additional limitations on cannabinoid potency or limitations on form factors without evidence-based justification, and that any concerns regarding dosage continue to be managed through these existing limits. Second. Can we get a roll call vote, please?
JD Lawrence,
Yes.
Matthew Page,
Yes.
Kent Anderson,
Yes.
Nanette Beresney,
Yes.
Desiree Hennessy,
Yes.
Misty Smith,
Yes.
Tammy Clark.
Yes.
Okay. Thank you very much. We're gonna move to, and before we leave that, I also, JD said that, you know, he wanted to say like, some people did some great jobs. I just want to say that even though, Dr. Forsyth is not necessarily a proponent of medical cannabis, he nailed it last week,
Mhm.
just with science. And that's what I say about this program all the time. I don't need you to be, a cannabis fan, you know, I don't, what we want here is at the end of, as this program, we just, yeah, at the end of this program or during this program, we just want to use cannabis in the ways that, you know, we can prove medical efficacy, and we don't want to do any harm. But we do recognize that there are definite people with need, and Brandon, Dr. Forsyth, he was.
I was waiting for him to correct me.
Yeah.
Anyways, thank you for your comments. They were very helpful because they were scientific and true. Yeah.
And very clear to non-science.
Yes.
Yeah.
Yes, so that was appreciated.
Non-scientists.
It was way better than what I said. But let's move to agenda item number 6. Low THC products and medical cannabis. With Brandon and Cody, we're just gonna get informal here, but I think Matt's gonna be doing the memo.
Are we turning over?
I don't know what order this is going, so you guys decide. Unless you want me to start talking, I'm happy to talk.
We don't have a whole lot. I do apologize for the confusion caused by the email that was sent out to producers, pharmacies over the low potency THC products. We understand that patients do rely on those products to help treat their health conditions. And the medical cannabis pharmacies are a reliable place to get high quality medication for patients, and sending them to another source for those types of products could really be seen as a risk for them. And so, yeah, we apologize for the confusion there. We're looking into the interpretation of the statute, make sure that we can enforce the law in the way that it is supposed to be enforced currently. And so we've drafted that email and we're currently investigating how to move forward. We did include in our legislative asks some potential changes that might need to be made to the statute in order to allow that to go forward. In the meantime, we just encourage people to continue on as they work and we'll try to get this worked out as quickly as possible.
Yeah. I like it. If anything, it was really great. Like we all came together on something, so that was nice. But Matt, do you want to read your memo?
I can, I won't really read it, but I'll talk to it. So I appreciate the communication with UDAF in regards to kind of putting this on hold. They acted quite quickly. It was within 24 hours that any stay on products was removed. So that way patients weren't impacted on their items. Just like in the memo states, I won't read through it all, but it was a month ago, during our last meeting, we did receive that email asking processors to put any product on hold, and pharmacies were to place them on hold and destroy. And so obviously it did cause quite a panic for a lot of pharmacies and patients who didn't quite understand what was happening. We understand there's huge value in low THC products that are also not only just low THC, but also products that are other minor cannabinoids. I mean, we heard many public comments over the last several months in discussing potency, the benefits that come with a combined and a approach to balance the THC with other cannabinoids. And so there are several products, and it's not, as a processor, we have roughly about 15 different products that would have been held to this hold, that are aligned. Most of them are low dose formulations that many children or other people that are getting into cannabis use for the first time. And where we weren't alone. I mean, there were thousands of products across the industry that would have hit this requirement to be removed. And so really the memo, all it's saying is, there are states that do limit THC. I wanted just to know, where Utah has taken a broad approach and not limiting what are in products other than just what is defined as a THC product. And that's what kind of the UDAP was going after. The definition does define a THC product as anything with 0.3 or higher. And so anything 0.3 or lower is considered as a hemp product. Where there is benefits in hemp products within the medical, as defined as a hemp product within the medical market. The current hemp market is saturated with products that either outside of guidelines, may not receive quite the testing we're seeing, aren't registered within the state of Utah to be sold. And so many patients or many customers are susceptible to getting products that may not be as highly regulated as what they can get within the medical side. And so the recommendation that I was looking at proposing in here, we have a couple ways we can look at it. I think one, we need a statutory change to redefine the 26B 4201(8) on what is redefining as a cannabis product. Yeah. Which I think if we can get that redefined, it will kind of allow us to do it. One of the concerns that may come in is we don't want to be overly limiting on what's in there. I think we want to continue to have the same strict testing and guidelines and everything else. That these products are tested and are validated through the state lab or whatever approved lab has been applied and given permission to do testing.
Yes.
And so, I know the state has already done a moratorium on the enforcement, so that's already been done. Obviously, I wrote this memo the same time it was these things were going through. And the secondly, we've already discussed this in public education, but this is definitely an area where public education could have helped out. Is making sure we understand, we do currently on the Department of Health side, they do reinforce, and we saw it in their presentation today. They reinforced the start low and go slow approach. And then, but by getting rid of this limit, it would remove that entirely from many patients. And I'd probably start them off with disastrous experience for their first foray into medical cannabis. And so, yeah, with that, that's my memo.
Yeah, I think I agree. There's a time and a place for not low THC product, right? I mean, there's plenty of people that need it, or obviously we would not be producing it. I do also love that we get to talk about both ends of the spectrum in the same day.
Well, it's really just an issue of definition, right? I mean, the way I believe the definition was conceived was to differentiate what was a hemp-derived product, a federally legal hemp-derived product versus what was medical cannabis. And I think that was the unintended consequence of saying, this is what medical cannabis is, therefore you can't sell what would otherwise be a hemp-derived product. But I think the concept all along is if it's produced by a medical cannabis, producer, it can have any level of THC or other cannabinoid. Obviously may want to limit, synthetics and different things, but I think it was more definitional, but maybe Cody can speak to some of that. But to me, it just seemed like it was a way to differentiate early on in the program between hemp derived and medical cannabis. And then it was something that just came up, kind of not intentionally when other things were being looked at.
Yeah, I think at the beginning of it too, there's different layers and just it being that simple. I wish it was that simple, obviously everything that's simple, but because there is, the farm bill and the definitions of hemp, THC products that are for non-hemp products, and supposedly in the federal government, but there is a true separation between this, obviously, state and what they're doing on cannabis and stuff, so. It could just come down to that definition change, but it also might be an overall thing we have to look at that starts to make sure we're not crossing barriers to allow other states to come into this program or some things like that, or so there's a lot of layers you got to look at to make sure because of the federal legality.
Yeah, to me, I think that's where that idea of making sure that it's ensuring that it's been produced by a licensed Utah producer hopefully does away with some of those, those concerns around interstate commerce and things like that. Hopefully that's, the requirement. But my understanding is this is a high priority for lawmakers and one I think they're hoping to put to bed early on in the session, so it doesn't draw out like most of the cannabis bills until the last day. But we'll see. But I also just appreciate, the department, while it caused alarm initially, just, being very thoughtful about pulling that back, giving some time to investigate it and hopefully let the legislature, work it out. Cause, just roughly when we looked at it, we had, 49 first party SKUs on hand or unique batches for a total of almost 6,800 units. And third party, unique batches, 32 for almost 3,000 units, right? So it's a significant amount of, of products, and ones that patients, really rely on. So I do appreciate the thoughtfulness of UDAP, subsequent to the initial alarming email. But I also understand that you all have a job to do as well. And the way the law currently reads is the way the law currently reads. I know last time we were here, Cody was filling a little bit. And I don't blame him, right? It's tough to put in that.
Earned Cody, it was earned.
But no, I do think that's important to recognize, right? Is that's why, clarity in the law, the best we can get it in all areas is important, because when it's not, it can lead to unintended consequences like this. And I'm not sure that this was ever even what was intended. I think it probably just, and maybe it was, maybe there was some intention, who knows, but hopefully that'll get fixed this next session.
The only suggested addition I would make to the memorandum is under the patient value of low THC products. I would add a third bullet for I don't know what you want to call it, but the medically fragile patient who is in end of life care, hospice. Patients who, because of you know, whatever condition, you know, are exquisitely sensitive to the products themselves. The low dose formulations are absolutely critical for for them.
That's a good
And,
point.
and there's a lot of evidence there, in terms of blood-brain barrier breakdown in certain conditions that exposes the brain to more. So.
Okay,
So Brandon and or Cody, where in this memo where it has the proposed statutory change that may come into motion here shortly, does that language that they have, right, to kind of change that definition in 26B-4-2018 to redefine a cannabis product as a product that is intended for human use, contains cannabis or any tetrahydrocannabinol or THC analog, and is produced through a state licensed production establishment? Would that proposed change in definition increase, decrease, or not do anything to the heartburn you guys may have based upon the conversation that we just had around federal law and interstate commerce and things like that?
I don't know, changes at all. With regards to refine that.
Okay,
I guess.
okay.
and also I thought that there was, JD, a piece of language that needed to be changed in the 441.
441A something.
Yeah.
You guys don't define it. do you?
1101.
Yeah, you refer to 26B, right? Okay, so maybe what would be the best thing to do is if we feel that language still needs to be refined a little bit, maybe there is a way between this meeting and next meeting to have some sort of collaboration with the department over what that is. And if we can't come to a consensus, because I think what we want to do is we want to support as a board a definitional change that will allow these products to be sold. But if the department has concerns how the language should read, I would hate to make a motion and support language that then has to be gone back on. I think it just looks kind of sloppy and messy to do so. So my recommendation would be to table it again for next month and maybe even future months, depending on what we hear from the department. And I'd be keen to know what those, those things are, because if now we're allowing the, medical cannabis producers to sell those products, low THC products here in Utah that, fit the definition of the Farm Bill, does that then open the door to others? Now, I would seem to think that requiring it to be produced, by a licensed producer here in the state probably solves some of that, but maybe not all of that. So that would be what my recommendation would be, is to come back next month, maybe with some language that we can work out with UDAF. And if not, maybe it's a simple motion next month to just say, hey, we support a definitional change that would allow these products. Maybe we don't have to get as specific, and you do that even today, but I just think I'd hate to go back on it and be like, oh, that language actually doesn't work. Now we have to, motion again. I'd rather get it all done in
Well,
one.
and I think just coming back to with some information on like the interstate commerce, what that looks like, if I know there's difficulty there, but then like if we just say licensed, does that mean that an MSO would be able to do it as well? Like I think there's questions. So maybe we come back, look at all of those, work with them on some adequate language. If that sounds good to everybody.
Public comment?
Yeah, I guess we can. Is there anybody in the room who'd like to speak to them? Please come up and state your name and who you're affiliated.
Okay, I'm Cindy and I'm a pharmacist with BMed. I want to say thank you for bringing these, when you handle that. I do have some concern about communication. I have worries, but I do agree with the pharmacist from law. So there is not enough low potency, higher CBD, CBG cannabinoid products in the market. So the communication I got from ag was only like you store these, and then the next email said, ignore that. I didn't hear any other communications, even in the leadership call. So can you let pharmacies know that this is being changed? So people who are buying products know that it's okay to put on their menu. They're not high sellers. So, and the same thing with processors. I do not want processors to think, oh, this is going to be a problem. I need to reformulate it and drop the SKU because they're not very lucrative. So if there's communication, to the rest of it? Maybe you do location of processors that I'm not privy to.
We're still looking into a lot of these changes, but giving any
Okay,
concrete reassurances at this point, plan to work out. So we're hesitating to give any information, but we can provide information if that makes sense.
okay, I guess, so when it does, I guess maybe you can just reassure everybody that these products are important. We want them in the pharmacies. That's the message I want. Yeah. Thank you.
For patients, think they do rely on these, and we want producers to be able to provide high quality patients food products. We just need to determine.
Yeah, and us in this room all know that, but I'm just thinking of the people that are coming to these meetings that are producing the products and they're buying products, and we're not pharmacists, they're not gonna realize how important that's are. Thank you. Thank you.
I am Chase again, Chase Angelo Giles. I just wanted to quickly say that, just as much as high potency THC products are important in my care, absolutely so are low potency THC products, a lot of which I get from, the hemp industry. And something that I wanted to, put out there is the intention should really be written into the law. Because when something is intended to be grown for the, medical cannabis program, even if it has 0.2% THC, the intention was still there. Just as much as if someone brings a hemp product into a pharmacy and it happens to meet the requirements, an extra step in there. The context then becomes, it could become a medical cannabis product in that context, assuming that would meet the requirements of the program as well. So my point is intentionality and what people actually intend for each thing needs to be considered, not just in the beginning, but at every step of the way. Because I think there's a lot of benefit to the idea of bringing hemp products, bringing our local brands into pharmacies, even though they are hemp. Just because when the push comes to shove, hemp and cannabis and medical cannabis are both cannabis and sativa L. The difference comes from the law. We just call them something different based on THC percentage, but in reality, they're just different combinations of all those different cannabinoids. Which different patients need different things, but many of them won't even think to like, oh, I need to go to a vape store, or something like that. So yeah, to wrap up, I think that, intentionality in those two contexts, when it starts off in the program or makes its way to the program, need to be considered. I think that's, in my view, the best path forward. I just wanted to, it's okay, I'll leave that for another day.
Thank you.
We're here.
Anybody online? B.
Oh,
Okay. Well, then let's. I guess we don't need to make a motion to table it. We do make a motion to table it.
I don't know if you need to, but.
Yeah.
Yeah, I mean, I can just make a motion to table this for a future agenda item.
Second.
All in favor?
Aye.
Okay, perfect. Let's just work on that and then in from here and. Hey, we are cruising along, so, number 7, we're just talking about next meeting's agenda, so it's coming up on right before, the legislative session. A lot of bills are already being drafted, so if anybody has anything that they need, on there, I think maybe now's a good time for us to just talk about what we need on, our agenda for January. I think we don't ever have to talk about potency again, maybe, except for low THC potency next month. But what else, is there anything from you guys' respective fields that we need to bring up or discuss before and have on the agenda eminently?
Expanding conditions.
I love Nanette. She's just not afraid to tackle the hard stuff. You know what? Nanette wants to do a memo on expanding conditions.
I can offer that is a topic. We had one of our first research review board meetings for CMCR. And that's something that was discussed. And it's under, the list is under review right now. So there is action on that.
So should we wait until you're done with that part before we?
I don't think one should be exclusive of the other. I'm just letting you know that that is something that's currently being reviewed. And I actually provided them a list of things that we had talked about at past meetings as potential areas that are worthy of review. So those topics that were expressed before, I kept a running list of, and I brought that to the board. So
Yeah.
they're in the lists that are being, looked over and prioritized. So, yeah.
Thank you. That's good. Yeah. So, okay, so maybe is that on our tracker?
I believe it is.
I think it is too. So let's talk about that in our meeting in a couple days. Because I think that would be a fun one to tackle.
And maybe it's just a discussion.
I think it's a
Even
conversation.
before
Yeah.
having to have
Yeah.
a full memo, just so you can maybe get a general idea of where.
And
some
if
things
there's
are.
something that we as a board feel passionate about that should be looked at to get the evidence to support it, then that can be passed along. I'm happy to add to the list, so.
Yeah.
Yeah.
Okay.
I mean, we did discuss qualifying conditions previously.
Mhm.
Yeah.
The board has made a recommendation, just so.
Did we make a
Yeah.
recommendation? That's what I was just trying to remember.
Yes, we did. Recommendation I was not at all happy with, but a recommendation that we made nonetheless.
Well,
It's very limited.
Mhm.
Very limited in terms of what would be, I believe, in terms of what would have been needed. So I would like to advocate for a position that several states have taken for a kind of catch-all provision that allows doctors to be doctors and use their professional discretion in recommending cannabis. I don't, I get it. It's not without limitation. Shouldn't, things should obviously be considered, but I just think it's interesting. Seems to be the one medical condition I'm aware of one medicine I'm aware of that has a subset of conditions set forth in law. I know
Right.
there's other places where those things may be set forth, but that's the position I've always advocated for. Let doctors be doctors. You can have an enumerated list. I think that would make many providers feel comfortable saying, hey, I've chosen from this enumerated list. But I also think you'd have a number of doctors who are comfortable, with, I guess we can say off-label. I'm not sure it's really off-label, but off-list, recommendations. And I think you're seeing that as the prevailing trend across the country. I think you're seeing more and more states going in that direction. I know we talked about removing the list altogether, but which I think there's a lot to be said for that also. But yeah, I think that's the prevailing trend of where things are starting to be headed with this. So.
Well, and I think that in my mind, it was getting to there needed to be done in steps, and we have taken one of the big steps, which was removing the requirement that not all doctors could do it. So now
It's just building on that same thing. I think telehealth is the exact same type of stuff. I think form factors gets into similar types of things as well. We as a board, right, recommended, chocolate directly, and that was written out of the law specifically, even though there was evidence to support it. So I think it is all going in that direction of normalizing cannabis as a medicine. If we're going to treat it as a medicine, we got to treat it as a medicine when we want to, and even when we don't want to, right? I think so. Yeah, I'm wholeheartedly in support of those things, as well. And those will continue to be priorities for us as a business. And just, it's the right thing to do by patients and providers. If it's medicine, it's medicine. If it's not, it's not. Let's just continue to have that same conversation about it.
Agreed. I really agree. I do think that we're building the blocks in order to be able to set up the state so we can do this in a safe way. And I think this conversation could be completely different than our last one. So.
Certainly.
Okay, well, if nobody has anything that they feel pressing to have on the agenda before the legislative session starts, then if you do have anything you think of in the next couple days, reach out to Nanette or I, and we will make sure that it's talked about in our next planning meeting. And
we should definitely just make sure that if I think there's interim again in November, right? Brian, is there interim again in November?
Yeah.
I don't know if the governor's working group will meet again then, but if they do, let's just make sure our meeting doesn't happen to fall on that same Tuesday. I know we were lucky this last time that it didn't.
But we changed ours, didn't we? Because it's normally the second Tuesday, and we moved ours back a week.
So let's just if that has to happen, let's just be prepared to maybe pivot if we need to.
we communicated to the staff up there, hey, just so you know.
They move theirs.
This board meets third Tuesday of every month, so I think that's why it's the second, this.
Well,
Okay.
We've got more people.
Yeah, there you go.
Okay, well, with that, then I think we're done. I will take the next motion.
Matt, you make it your last time.
Yeah.
Motion to adjourn.
Second and approved your names.
Done.
thank you, Matt.
Perfect.
Thanks, Matt.
Yeah, thank
I'm sure
you,
you'll
everyone.
Be here next time, but maybe just not at the table.